learning qualification. I will be managing today's chat box, so please do pop in your questions into the chat box, and we'll have a chance to pose these to our speakers as we go, but there'll also be some discussion time at the end for you as well. I'll now hand over to Jo.
Hi everyone. So like Sian, I'm also on the steering group, and I'm also a NHS England, Northwest England facilitator for social prescribing. So I'm absolutely delighted today to welcome our 4 speakers. We've got a really exciting agenda for you, which is covering everything from a huge aspiration to embedding cultural prescriptions in social prescribing everywhere, and how we need to do that and make that happen, through to understanding how we can understand perceived barriers that may be impacting on embedding social prescribing through some research with GPs. We've also got a focus on how we ensure we achieve effective system change, and with that increased funding flow. And last but not least, basically we have a whole backdrop about understanding each other's worlds, and the implications for service design. So where we're in different areas of the system, the importance of understanding those worlds and developing common language. So without further ado, we've got quite short presentations, but we're still going to try and get some immediate questions. And I'd like to open with Suzy from Barts, London School of Medicine and Dentistry. So over to you, Suzy.
Hi everybody, hello. Yeah, my name's Suzy Wilson. I'm a professor at Queen Mary University in the Barts and London Medical School, but I'm also artistic director of a theatre company called Clod Ensemble. We have a project called Performing Medicine that has been running for nearly 20 years now, where we work with healthcare professionals within the NHS and community health, bringing arts and culture into a kind of support and professional development for healthcare professionals. So today I'm going to talk to you about a project that we've been doing in relation to social prescribing. I'm going to share my screen. Hang on a second. Hopefully everybody can see that. So yeah, so as I said, Performing Medicine is a creative training program for healthcare professionals, and we've been thinking about kind of social prescribing and being aware of the social prescribing movement, because it seemed to us that many of the kind of participatory arts projects that we'd be involved with could actually come under an umbrella of social prescribing. And as the body of research and evidence built around social prescribing, and when the Creative Health Report came out in 2017, it felt like one of the main challenges was how to develop the workforce for this area of work, so that health professionals and artists could understand each other's practice, because it felt to me that there was quite a big kind of communication gap and some language barriers between those two sectors. And we soon realised, in order to set up this workforce development programme, that we'd need to take a really localised approach, because there's so much confusion about what social prescribing is. Often people get very immediately start talking about where's the money coming from. Social prescribers are called different things in different places. So we felt like we really needed to understand a particular local area. So in 2021, we piloted a project in Southwark and Merton. And we identified 3 different professional groups: the artists and arts organisations, the social prescribers and link workers, and healthcare professionals. And we piloted a workforce development programme which consisted of 4 modules over 4 weeks. And the aims was that, as I've said, that each professional group really got more of an insight into each other's worlds, rather than there was a feeling that sometimes the arts organisations might come in and impose what they thought were the problems were on a local area, rather than really understanding how social prescribing was working and what were the needs of the people in that local area. We did an evaluation of the programme, and it was overwhelmingly positive. And so as a result of that pilot, we're now in the situation where we're delivering this programme of work to priority boroughs in London. And that's starting with starting with Croydon, then we're moving to Brent, and then we're also doing a kind of version of this programme in Enfield. And so the original project was funded by Greater London Authority and Healthy London Partnerships, and now we're being funded by the Arts Council as part of their strategic programme. So here's just a visual to show you the programme delivery. Those are the 3 cohorts that I talked about. So each module, first of all, happens for each individual group. So in a way, it's allowing each group to talk about their needs, their challenges, the ways that they communicate in separate groups. And then in the 4th module, we bring all those groups together to begin to make connections. And at the moment,
Suzy,
yeah.
Could I just ask, we've had a question, someone's having difficulty seeing the slides. She wondered if you could make them any bigger. I know on different packages, people can do that. Wasn't sure if you were able to.
I'm trying to, but I might ask Liz, have you got any idea? I've got a colleague who's younger than me and therefore maybe he's able to zoom in a bit. Oh, yeah, is that working?
That's it, thank you.
Thanks, Liz, fantastic. What's happening now? Okay, oh, no. Yeah.
Brilliant, thanks.
Okay, great. So yes, so the sessions are 2 hours long, and then the module 4 in Croydon will be a live session with everybody in the room. The rest of the modules are happening online. In terms of programme content, it starts off with really being quite kind of back to basics about what actually arts means, because often people don't, have an idea of what the arts are, but perhaps they haven't had much experience of the arts. So we've kind of split it down into different categories, which are obviously overlapping: movement and dance, music and singing, books and writing, museums and heritage, visual arts and galleries, crafts and making, and theatre and performance. Self-care and effective communication kind of run throughout all of the programme. So there's a real emphasis on how people who are working in this field can best look after themselves and their colleagues in which are often quite challenging environments. The second image in the middle, which is probably very small, you can't see it very well, but this was, here we are, there you go. What we realised was that a lot of link workers and social prescribers use Maslow's hierarchy of needs a lot, and that's not actually that helpful when we're talking about social prescribing of arts and culture. So we've kind of re-put those needs in a circle and hopefully shown that actually, by engaging in arts, it can help people access some of their more basic needs. For example, people were saying, how can I recommend someone goes to a choir if they're having problems getting benefits? So we're trying to kind of demonstrate how actually engagement in the arts can help people to gain confidence and skills in order to be able to address some of those more basic needs. And we use case studies, so that this is Kemi's story, an example of a woman who met her social prescriber, and even though her kind of personal circumstances were really challenging, the social prescriber found out that she was really into photography. And by joining a local photography class, she was actually able to access help and support to help her with other areas of her life. The impact. So from social prescribers and healthcare professionals' point of view, somebody said, I think I had written off these sorts of arts-based groups for some individuals before these sessions. It has made me rethink and reflect on lots of people who I missed, where I missed an opportunity to refer out to these groups. And I suppose an important thing to say is that, especially with social prescribers, we were really focusing on them understanding the culture of the arts and giving them lots of examples of both national and local case studies in the sessions that we were doing with them. With the artists, we were really focusing on helping them understand the needs of the local area, and the networking event was fantastic because they began to talk to each other about what projects could work in that area. And our kind of main focus really with arts and arts organisations was about what language they use and understanding what the social prescribers needed to know in order to refer people to those sessions. So artists and arts organisations, I've realised how amazing the link workers and social prescribers are and the breadth of need that they are working with, also how much need there is for this work and the strong desire to make this work. Everyone wants to find ways of linking up and sharing. Yeah, so I suppose by having these groups independently on their own first, people were able to express and kind of air some of their prejudice and assumptions about the different sectors and actually explode some of those, so that by the time they got together, they could have a really creative, constructive conversation. So just to kind of sum up, because I know we haven't got much time. Cross-sector working, continuing to try to forge dialogue between this interprofessional community seems really important. It's not just another training course, but it's a course that lays the foundations for future development of interprofessional expertise. And it's something that kind of shifts and changes as the social prescribing sector develops, and that we stay responsive to the needs and the situation that's happening in the local areas that we work. We need an accessible, common language with which to talk about this work in a way that includes everybody, from professionals to patients and participants. It is vital to build confidence around how to begin to start these conversations that may improve access to arts and culture. This idea of practicing well, professional communities looking after themselves as well as others is really key to this kind of work. And that social prescribing offers need to utilise the local resources in order to meet the community need. So, I mean, in 6 minutes, it's difficult to kind of go into detail, but basically, to kind of finish, there is a lot of demand for this work, and it feels really exciting that at the moment both the arts and the health sector coming out of the pandemic are really open to us kind of continuing in this way.
Suzy, we've not had any questions, but I wanted to pose one for you to hold on to for later. Just in relation to understanding about groups within the workforce that might be easier to get on side. As a result of the pandemic, are there any particular clinical areas you think that where the conversations might be more fruitful? I'm particularly thinking about the resurgence or the amount of tics that have come to the fore during the pandemic with young girls. I'm also thinking about loneliness and isolation, but I'll shut up there. Hold on to that, have a think, and we'll explore that further. But I'm going to introduce our second speaker, Laura. So we're moving to Ireland, and Laura's from St James's Hospital, Dublin, and she's been doing some work around attitudes of GPs to social prescribing, and really interesting to hear what she's got to share.
Hello there, thanks a million for having me. Yeah, my name's Laura. I'm working in geriatric medicine in Ireland. So we have had to do a study in St James's Hospital. So just a bit of a background, social prescribing in Ireland is reasonably well established, particularly in the northwest of the country. But it's as part of our new healthcare programme, it's been rolled out across Ireland and is popping up in different areas. But our catchment area in Dublin South Inner City has a social prescriber, and that's where we based our study around, just to identify the different I suppose barriers and attitudes towards social prescribing in the area. In St James's Hospital, we have the first hospital-based social prescribing programme in the country, which was established just last year during COVID, which was a difficult time to do anything social. So the aims of the study, as I said, were just to look at the attitudes and experiences of GPs towards social prescribing, and then to identify barriers to the use of a social prescriber within primary care in Ireland. So it's a descriptive study, a survey that was posted out to the GPs in our immediate catchment area, which is a large academic teaching hospital in Dublin city centre. We posted out 89 and got 48 back. So it was 26 questions. Some of them were yes and no questions. Some had free text, and then others were based on the Likert scale, where somebody could agree or disagree with a statement, which I'll go into a bit later. We covered broad themes, themes that have been outlined in the literature previously, such as characteristics of the GPs themselves, and then their understanding of social prescribing and what it means and who can benefit, their access that they have and the use of the service. And then in terms of the Likert scale, we asked them to rate different barriers to social prescribing as we had found previously, and also rate how they agreed or disagreed on statements made by other GPs about social prescribing. Just briefly, the key findings on the GPs themselves. We can see that a significant proportion were GPs that have been in practice for over 20 years, and probably nearly 2/3 had been in practice at least 10 years. And they're from quite large practices, with maybe 1/3 from over 5 GPs within the practice. Then moving on to the topic, so awareness of social prescribing. 61% were aware of social prescribing, but only 23% had access to a coordinator. And of this group, only just over half had actually referred to one in the past. Interestingly, over 60% of GPs felt that they actually do, practice this in their daily jobs, which we would have seen before. Regarding barriers, so awareness of services, 55% agreed that this was a significant barrier to using the service or referring to the service. Around 1/3 felt that lack of feedback was a significant barrier for them personally, and a similar amount agreed that forgetting about the service's existence is indeed a barrier. Over 2/3 agreed that they felt it was hard to refer to a service when you don't fully know what you're referring to. Time is another one that's come up a lot, and especially for GPs with their small, short appointments. About 34% felt that lack of time to discuss these social issues was a barrier, and then a similar number found that lack of time to even discuss a referral is a further barrier to the referral itself. And similarly, about 30% agree that it's difficult to broach that sort of a subject with the patient when you've only your 10-minute time slot. So just to compile, some of the attitudes regarding the role of a social prescriber for patients, 75% agreed that it could increase a patient's self-esteem. 70% agreed or strongly agreed that it allows patients to take control of their own health, and over 80% felt that it was a good way of encouraging people to help themselves. So really positive messages coming from the GPs in the area. And thankfully only 4% of GPs felt that it was only their responsibility to address medical needs, and also only 12% felt that by the time the social problem has been expressed, it's likely too late. So that's positive for us. So what did we learn from the research? I suppose we again felt that major barriers were the time, awareness of the service and its availability to the local GPs. And as I showed the brief statistics, that the opinion of GPs in the area is very positive towards social prescribing, and there is a strong feeling that it's got a good ability to improve a patient's quality of life. I think what came out through a lot of the questions was the importance of governance and feedback. They want to know what they're referring to. As, you know, is there sort of police vetting? Is there are these services reliable? Are they going to be available year on year? And are they going to feed back to see what the outcome has been, to close that loop for the GPs? And so that's very understandable. So I just put up a few quotes from the free text areas there about what these certain GPs had understood. So obviously there were many, you know, about 40% that did not understand much about social prescribing. So the message isn't fully out there yet at the time. But a lot of them did feel that it was, you know, around, you know, the use of social services to patients, to help patients with everyday life issues. So slightly not quite what we would see. And then use of non-pharmacological activities as a treatment or adjunct for an illness or complaint, which would be very accurate. And then other comments, you know, improved awareness is needed on social prescribing. Definitely, we need robust pathways for the service users, for the referrer, and for those leading the service. It's the way forward, so very positive, handing health back to the individual. And this last GP sort of was very much had good experience with it in the past, but also has said what we have found, you know, that it's important that there's a proper structure in place, that we can, you know, close the loop, have an idea of what's going on with the patient afterwards, and did they benefit, and so you can learn from the next time also. Next steps, I think we have to make sure that the GPs, the general public, and then the community teams on the ground are aware of social prescribing in itself, and then the availability in the area, and to have a good feedback process and referral process in existence. Time pressure is a limiting factor, and it's going to be a difficult one to really see changing, especially for GPs. So I think things that they could do, just keeping referral process simple, and making sure that other healthcare workers or community workers, public health nurses, can all refer into social prescribing also, and most do take self-referral, which is obviously very useful, so that nobody misses out on the opportunity to attend social prescribing.
Brilliant, Laura. Well,
Thank you.
certainly hotted up the questions. I'm not sure where to go in terms of how many we've got, but
oh gosh.
I'm going to cherry pick. I'm going to pick Ruth Ann, who's made a question in relation to about how we sell social prescribing to GPs, because I was holding in my head, if we didn't get any questions, how do you get into and under the skin of GP practices in relation to those that might be more easy to influence? So did anything come up when you were discussing with the GPs ways to influence and promote social prescribing directly through their networks? So how you infiltrate their networks, etc.
Yeah, I think one of the most positive comments I had in the research was from a practice that had been part of a pilot. So even just having a social prescriber go out for a little while and sit in the practice, and that practice actually ended up hiring their own social prescriber out of their own pocket, so I think that's the best outcome. So maybe just seeing the work they do on the ground, you know, is probably worth a lot more than all the brochures we could send them, you know.
Absolutely. And so thinking how you might influence them going forward by, in effect, creating a GP champion who would proselytise for the services. Well, we're going to pick up the rest of the questions at the end. So don't panic, anyone that's posted. Laura, I think you can see the chat anyway, so you might want to have a look at some of those questions coming through. But I'm going to move swiftly on because they are really short time slots, but we want to make sure we get that discussion at the end. So I'm going to hand over to Adam from MEL Research in Birmingham, who's been working with Keighley modality, who's going to help us to reflect on how we influence the system and create systemic change, and with that increase funding flow. So over to you, Adam.
That's great. And I've got to do all of that in 10 minutes, so a real challenge. But lovely, great to be kind of sharing today. So I'm the kind of Research and Evaluation Director at MEL Research, so an independent research agency. But we've done quite a bit around social prescribing, and the kind of project I'm going to be using today is in Keighley. I've got a little bit more about kind of Keighley. So Keighley, you may or may not know it, but it's a kind of a market town just outside of Bradford, part of Bradford district, so kind of within Bradford Council's kind of remit in West Yorkshire. It's quite an ethnically mixed, quite a diverse population there, South Asian, East European, kind of wider European as well, kind of Romanian, Portuguese, so quite a mixed group. But also very deprived, actually quite a deprived part of Bradford. Outside of Bradford and surrounded by some lovely kind of scenery, lovely area, but actually maybe a little bit distant as well, and that might be part of the, part of its isolation. So Power to Change and Give Bradford have kind of come together to put a funding pot over a few years to support really a community-led health offer. So this is kind of health being delivered, public health, targeted health for certain groups, definitely around health inequalities for those living in and around kind of Keighley. There were small and medium-sized grants offered, and it is kind of quite small. Maybe that was one of the feedback actually from grantees. The smallest was about £4,000, and the biggest was £15,000 per year. So it could be, over 2 years, and a few of the projects actually gained funding. A few of the organisations gained funding for a few years. It's still in process now. And modality, so a GP practice, kind of super GP practice, and primary care network there has also been involved. And actually, they've really, Laura said about funding services. They themselves have funded a community development role, and actually, he's been a real kind of important intermediary between kind of commissioners, the healthcare system, primary care, and the voluntary and community sector. So actually, really kind of quite a central role, quite an important role in and around Keighley. So our evaluation has been mostly qualitative, kind of virtually finished now, with a range of stakeholders, so grantees, strategic commissioners, representatives from the voluntary community sector, and others, GPs too. And really our evaluation aim has been kind of two of them, looking at the community capacity building. So can these types of organisations, can community organisations and businesses deliver this type of public health social prescribing services? And also, how can it influence system change? And how can it influence the kind of funding moving from a statutory basis into communities and towards community organisations? What it's not been, and I guess I've been reminded by our kind of clients here, it's not about testing social prescribing itself. They're happy that there's enough evidence for that, and I'm sure you've heard about some of that throughout this conference. So that's not what it's been about. It's been a different type of project. So just mindful that time is tight this afternoon. So some of the key findings, really, it's, COVID-19, we can't get away with it, can't get away from it. It's still here, and it's been an important element, I guess, posing challenges and opportunities over the last few years when the programme has been running. So challenges, as we all know, kind of accessing services, but even, the social prescribers based in GPs weren't actually physically in GP settings, even they were working from home. So these community organisations, even to meet and go to GP settings as they planned, just wasn't possible, wasn't viable. But there are opportunities too, setting up kind of virtual counselling systems, expanding services even outside of Keighley, because in a virtual world you can open up further afield. But also some of the community groups working with Pakistani, Bangladeshi residents, they supported opening up a mosque to run as a vaccination centre around COVID. So this was forged from the relationships between the community organisations and primary care from this. So, real kind of opportunities, real kind of tangible opportunities there. I think what we've also found is that the voice of the third sector, community, businesses, community organisations, charities, is being heard. You know, there are representatives within strategic commissioning discussions. So in terms of deciding what the priority is and where funding might go, the voice is being heard. I think what has to happen, and probably isn't quite happening, is the funding following that. And I guess within the third sector, within the voluntary and community sector, we've also kind of seen some tensions there. And maybe they're inherent, maybe they're built into the sector. Whereas local, small, community-based organisations understand their community best, are made up of their community, are within their community, they're quite small. You know, directors doing lots of different things, is fundraising for the next project, for next year, for the next quarter. There's a lot going on. Whereas big national organisations will have a fundraising team, a marketing team, a campaigns role, maybe better known by commissioners, you know, a bigger national presence, maybe better ability to win contracts, but maybe less on the ground know-how. So there's a bit of a kind of a tension there in terms of how do we shape this, you know, who is best placed, but also it is best in the best opportunity really to deliver some of these services. And I think what's been important, what's been nice from a kind of research and evaluation point of view is how it's helping to influence some of this change. Now, I'm not going to say it's all down to me. I wish it was, but actually I think kind of Bill Graham at Modality, the community role, has probably got much more to say about that. But I think it is influencing, and it's helping to support the evidence to support this 1% left shift. I think there's a real push in Keighley and wider there around Bradford to have a shift in funding, a 1%, you know, a kind of a pledge to fund 1% of healthcare funding into the community sector. So that's great, and I think this is about building that. Of course, as we know, working in health, it's a changing, forever changing landscape. I'm sure we all feel. So there's different players involved, different commissioners, different priorities, as well as COVID, of course. So, you know, we're teasing that out, but that is the background. We've been producing case studies as well as part of this as some of the outputs from our research and evaluation, really to help influence strategic commissioners, but I think also those kind of managing commissioners, those kind of day-to-day ones on the ground, managing projects, reviewing bids as they come in. So we have a stakeholder workshop actually next Friday, so I'll be up in Keighley, which will be great next week, and that will be bringing grantees, so organisations, community organisations, as well as strategic influencers, commissioners together. And what I'm really hoping to do is have a kind of a pledge board, you know, somewhere kind of quite visible where people will say, look, I'm committed to doing something, and I'll kind of put that there, put their name against it. So you know, I hope I'll be, you know, I'd love to see that after next Friday. So really, it is about how it's influencing some of the change, and hopefully we'll continue to do that. So just a few kind of key conclusions from our kind of evaluation. Funding really does need to follow the patients. As one GP told me, you know, the money needs to follow the patients out of the practice and into community organisations. You know, for now, there's statutory funding for GPs, and there's pump priming funding or other fundraised money for community organisations. It's not linked up, even though there are words, there's support for a 1% left shift. So, you know, the funding does have to follow the words. But also, and I guess we've kind of heard of some of this already today, about that real crucial role of locally rooted organisations within their communities and of their communities, really understanding their communities, and in lots of cases probably being best placed to deliver services, but might not have all the infrastructure support, all the kind of, you know, the back office support that others might have. Lovely, thank you.
Thanks so much, Adam. I'm just going to sow a seed again. I can't see anything directly related. I think people are reflecting on what you've been talking about. But I just wondered, in terms of the pledges, and hang on to that, how are you going to bring that report to life beyond those pledges? What might you do next? because so many times amazing evaluation reports sit on shelves and we don't in a sense amplify them. So hold on to that, and I'm sure there'll be other questions before we finish. I'm going to move on to our last speaker now, and we have Sara from Queen Mary University Hospital. Sorry, Queen Mary University, obsessed with hospitals today. And she's going to help us to explore how a better understanding of social prescribing and a shared understanding helps support service design and its development. Oh, you're on mute, Sara.
Thank you. Am I now unmuted? Thank you. I'm so sorry. Thank you for the introduction. Yes, I'm Sara Calderon. I'm a GP in the Bromley Bible Health Partnership in Tower Hamlets, East London, and also PhD student at Queen Mary University. And the title of the presentation today is "What does the literature mean by social prescribing?" or what are we talking about when we talk about social prescribing? Let me move on. Yeah, so as you know, social prescribing initiatives, interventions are developed and implemented within a wider social, cultural, even political context, right, where different and often competing priorities, interests, and expectations coexist. And actually, as highlighted by Rempel and colleagues in this systematic review, the intended aims of social prescribing programs often vary and can be different for different stakeholders. And actually, some of these reasons have been mentioned today, like from cost savings to reduced service utilizations, also improvements for patients' mental, physical, or social well-being, etc. So across the literature, we see that social prescribing initiatives have often different aims, different priorities, different ways of measuring success, and also different understandings of what success in social prescribing means, right? And therefore, we decided to ask ourselves and undertake a literature review to explore how social prescribing is framed and understood in the literature, in the scientific literature, and maybe most importantly, to investigate whether, and if so, how these different ways of understanding social prescribing influence the way services are designed, delivered, and evaluated. So what the real implications of these framings of social prescribing are, right? And so we reviewed academic articles and also grey literature. We used discourse analysis and followed the 5 iterative stages displayed here in the slide. And across a total of 89 studies, we identified 3 different ways of understanding social prescribing. So some studies, some stakeholders emphasized increasing social inequalities behind escalating health problems and presented social prescribing as our response to the social determinants of health. Others problematized people's increasing use of health services and then depicted social prescribing as a means of enhancing self-care, independence, reducing their reliance in healthcare. And here, normally lack of motivation, lack of confidence was considered a barrier for behavioral change instead of maybe a structural constraint. And hence interventions had a very a strong motivational coaching approach and component. And then third, lastly, others stressed the dearth or the lack of human and relational dimensions in general practice, which was often depicted as very fragmented, impersonal, very rushed, and claimed that social prescribing could restore patient-centeredness and personalized care. And note that these 3 ways of understanding social prescribing are neither mutually exclusive, nor they exclude additional alternative framings of social prescribing, right? But certainly they were very present and were quite dominant in the literature that we reviewed. And somehow, as you might have been maybe able to identify already, across these 3 ways of understanding social prescribing, there was somehow a shared tendency towards framing social prescribing in terms of solution to quite complex and very contentious problems, such as social inequalities, overstretched health services, increasing fragmentation in general practice. And we also found that these ways of understanding or social prescribing shaped somehow the way interventions were delivered, very often one-off, with boundary setting strategies in place to prevent dependency, with a strong, again, motivational component. etc. And we argue that this can be problematic on the following basis. First, because good practice in social prescribing may not necessarily involve reduced service utilization. As you all know, we saw that link workers often identified problems which required further clinical input, and in such cases, patients were referred back to general practice, and that is absolutely okay. That is actually good practice. It should be encouraged and valued, right? And we also know that adhering to behavioral change, be this lifestyle related, financial, etc., is an ongoing struggle for the most deprived, especially if underlying constraints and drivers persist. And hence, support will likely need to be sustained, right, in order to be effective, in order to effectively counteract the consequences of ongoing structural injustice, as Michael Marmot highlighted yesterday. So we end by suggesting maybe an alternative care-based framing of social prescribing, which maybe could understand the provision of holistic, sustained, accessible primary care, not so much as a means to an end, as a solution, but as an end in itself. And maybe from a research perspective, this would require shifting a bit the attention of research from measuring impact via service utilization indicators to evaluating the extent to which social prescribing may or may not succeed to support people in greatest need while contributing to a stronger, fairer healthcare system. So yeah, to sum up, we've seen how well social prescribing is understood, seems to have relevant implications for service design and delivery. We've seen that current ways of understanding social prescribing may contribute sometimes to oversimplify a bit both the realities and the problems being addressed and constrain the way interventions are delivered and evaluated as well. And we end by proposing an alternative care-based framing of social prescribing, which prioritizes and evaluates as well holistic, sustained, accessible practices within a strengthened primary care systems and communities as well. And thank you very much. Very happy to discuss further in the Q&A.
That's brilliant. Thank you so much. I'm going to partially hand over to Sian here, who's going to be fielding some of the questions from the chat, but also please feel free to use the raised hand function as well. So Sian, do you want to start in any particular area, and I will chip in with additional questions as well if we need any.
So I think the questions in the chat you've already highlighted to each of the speakers as they finish speaking, so you possibly should start there to begin with. So in relation to some of those questions, though, I was thinking we obviously picked up with Ruth Ann, who was talking about how do we sell social prescribing to GPs, which is really a similar process to whoever we're talking to, whether it's patients or whether it's in secondary care and acute settings as well. So I'm just wondering, in terms of the speakers' experiences, is there any techniques that you've particularly used or been aware of through your conversations? Does anyone want to pick that one up?
I can say something to that. I mean, I think obviously over the last 2 years, particularly the workload of GPs is even the GPs who are really open to it are finding it very difficult to find the time to engage, especially within these kind of group sessions. So in talking to some of the GPs in the kind of scoping for this, they're recommending to us that there's much more kind of marketing presentations at GP conferences for kind of broader groups, a kind of awareness campaign, because I think GPs, once they see the case studies, national case studies, I think it's really helpful. And also, rather than making this dichotomy between kind of social, you know, they'll refer patients. I mean, there's a lot of arts projects that, you know, really help in stroke recovery, in long COVID. My experience is as soon as GPs kind of buy into that, they can see that loads of other GPs are interested. So I would say there needs to be a kind of broader kind of campaign aimed probably at conferences. But the person in the chat who said, how about kind of going around a bit like a pharmaceutical company would to local GP surgeries? I think that's a kind of brilliant idea, like a local engagement representative, because in my experience with this work, it's really labor intensive, and it's kind of about relationship building, one person at a time, and you know, the more understanding, the more champions you can get. It kind of builds and builds, but we're certainly not there yet. But yeah.
So what strikes me about that is that there may be quite a significant cost implication. GP conferences tend to be very pricey, and we've also got some legislation going through at the moment in terms of the ICSs and much more devolution happening. So I think conferences are great because you can always twist people's arms and try to get free places, shall we say, in terms of the marketplace. But there's something very important about the locality and those ICSs emerging. And I'm just thinking as well in relation to that, some of the more pressing issues that we're picking up from our primary care networks is not only overload with work, it's staff well-being. And I kind of put that out there because that's a lever, because they're very keen to ensure that primary care is a first destination for clinicians leaving training, but also we're losing 400 NHS staff a week. So they're very, very keen to ensure we retain those staff. And I'm just wondering whether there's something around packaging a social prescribing offer for NHS staff. And to give you an idea of what's already happening, which is getting some traction, Health Education England had produced something called Uplifting Resources for the NHS, which is a cultural prescription programme. And there's been quite a bit of recognition around that. So that's one example of using a real priority at the moment in terms of retention. But what's also in that field is it's not just about some of the big players like NHS England. Health Education England at the moment till 2023 is responsible for workforce development, and you have Health Education England offices in your localities. I'm wondering how many people are talking to your local Health Education England teams, but also your academic health and science networks as well. So just kind of thinking that it's no one size fits all, is there? So we've got a question. Sarah's just asking a question as well.
Oh yes, sorry, myself. Yes, so I wanted to maybe answer regarding the question how we increase awareness of GPs. I found in Tower Hamlets, especially in the research that we've been developing, the co-location. So the fact that the link workers were embedded in the practice, that made a huge difference. And not only, of course, with COVID, it's been a bit more complicated, right? But now they're increasingly coming back, and that really helps not only to increase awareness, but also to enhance practice and how we practice, because we can discuss about patients, we can share relevant information, and the quality of the referrals, I think, improves. And also another way of increasing referrals, I think it's directly related to our working conditions. We need time. If we don't have time to ask about our patients' concerns, it's very difficult to initiate that referral. And that's why I guess the framing is a bit also important. If we frame this as a solution to rush general practice, I don't entirely agree. I think we need, good general practice to do good social prescribing as well. I think everything goes a bit together. That holistic approach needs to be throughout the process, right? Thank you.
Brilliant.
I also, just to kind of follow up, sorry, you go, Sian.
I think Adam was waiting to talk.
No, that's great. Yeah, thanks, Sian. I just wanted to kind of build on that. I think from our kind of work in Keighley, it's about kind of influencing at different levels. And I think that there's a real kind of hope and aspirations around that kind of community level influence in terms of what is right in terms of the health offer for the local community. And in Keighley, that's different to Central Bradford, that's different to North Bradford. So even a very kind of localised offer there in terms of social prescribing and what type of services are right. But I think also at a kind of a higher level, either the next level up or, ICS or beyond that, kind of regionally or sub-regionally, in terms of the real, the belief in community organisations, belief in local communities being able to prioritise services. So I think from the work that we have done, it's not just about kind of influencing GPs, because actually in Keighley, they all have, well, almost all of them have social prescribers already set up, and they've kind of won over some GPs more than others. So having a champion is great. But I think it's some of that kind of wider strategic kind of setting that is going to help keep it going over time, and yes, kind of fund services as well. And just lastly on that as well, I think the links, those relationships then form between primary care, between GPs and community organisations, the likes of the Bangladeshi Association in Keighley, has really then worked with COVID and beyond. You know, they can now trust each other, and I think doing that tangibly, you can see that carrying on in future. So,
Adam, you're very much picking up on something that was raised on day one of the conference by Dave Sweeney, the importance of leadership. And we sometimes have it in some areas, but not others. So I'm just wondering, how do we influence that as ICSs start to come to the fore? We'll pick that up again, but I'm just going to jump back to Suzy to make her point, and then we'll pick up some of the questions and try and open this up.
Yes, I think it's really back to this idea of how to attract GPs. So, and the idea of kind of well-being of GPs and stress management. So when because we do a lot of work with healthcare professionals and GPs, more in terms of kind of professional development, in terms of their own well-being. And when we started talking about social prescribing, many GPs were saying to us, if this has a well-being offer for us, you're going to get more GPs involved. I think for us and our kind of program particularly, that's complex, because there's obviously a need for this kind of work outside of a social prescribing umbrella. So I think there's a kind of, in a way, there's a kind of caution around social prescribing becoming a kind of catch-all for all professional development needs of healthcare professionals. So yeah, it's just, however, as I said, it does seem to be something that will, I suppose, entice GPs to get into the room in the first place. But there's certainly a need for something beyond the social prescribing frame for GPs themselves.
So if we throw into that mix, just thinking about the WHO assertions around creative health agenda, and Daisy Fancourt's points around the idea that the real advantages of cultural prescriptions address both prevention and protection agendas, but treatment and management. Do you think there's something around that continuum that things like pharmaceutical interventions can't offer?
Sorry, Jo, can you say that again?
So I was relating to the WHO documentation that came out. I think it was in the middle of the pandemic, sometime in November 2020, where Daisy Fancourt explored how cultural prescriptions can not only help and protect and prevent ailments and disease developing, but can also offer really innovative solutions. So we increase the toolbox for basically areas that don't currently have any treatment and management options. And a good example would be that we've had this huge increase in tics in young girls due to the pandemic, where they think it's to do with epigenetics, they're not quite sure, but they've got an issue of lots of young girls who can't go to school and not able to function. And our clinicians are kind of bewildered as to what can they do. And from my perspective in the Northwest, that's the first time I was approached directly by a clinician and said, we need social prescribing, what can you do? And the immediate response was, well, there's some really strong evidence around DANS, and that opened the door. So I'm just wondering if there's something around that. Going back to Sarah's points about understanding and how we frame social prescribing, that we're missing a trick sometimes, that we constrain the opportunity by being not necessarily ambitious enough.
Yeah, I think understanding the need and having conversations and seeing how people can collaborate, it feels like a kind of collaborative practice. And also in terms of terminology, I just think these terms shift over time. I think creative health is a really useful kind of broader umbrella term. Yeah, so exactly, kind of tailoring the conversation to who you're talking to and not getting kind of, even the word cultural prescription, I'm sure people have talked about this and they have been for years, but can turn a lot of people off. It's just like finding the access point. And I think in our program, just trying to have the space to start the conversation is really important. And then people can find a kind of meeting place in terms of the terminology that they're using. In terms then of government funding, that's much more complicated because we need a kind of terminology that a kind of funding stream can kind of sit within. But creative health, in fact, I had a conversation recently with the GLA who was saying, be careful not to kind of limit to the term social prescribing and keep the offer broad, especially at this time, to really encourage more artists and arts organisations to be able to engage with this kind of work. Yeah.
Brilliant. So Laura's got a hand raised. Laura, would you like to ask your question?
Just briefly, just adding as well, I think, I suppose coming at, as you were saying, there is good data about, tics and the use of dance, and like there's a lot of data out there, and focusing on that side for GPs, like going with, that's what they probably want to see. They want to see evidence-based, and there's so many strengths there to use that to sell to them and to maybe target their colleges. Like, you probably have the Royal College of GPs, we have the Irish College, that targeting them first to then put that into their teaching for their trainees, their registrars. That'll help to get the word out a bit more, maybe.
And do you think there's something around collaboration as well across the piece outside of our own regions? In that I'm thinking there are things that are in the system at the moment. So in February had a soft launch of social prescribing for children and young people. And we know that they have a whole range of needs around loneliness and isolation. And we know that there is a need for a range of wellbeing journeys to be co-curated. Maybe there are some easier targets and ways to start having these conversations, because GPs are going to be faced with these potential referrals for children and young people, and they're not their normal customers, shall we say. So I'm just thinking, again, in relation to that, going back to Adam's points about leadership, I wondered how many of our speakers are connected into your academic health and science networks. Anybody? So they sit on quite significant amounts of funding, and their whole focus is the innovation arm of the NHS. And I've certainly had conversations with a number of colleagues within AHSNs about why social prescribing is not in there alongside digital and pharma. So maybe that's something that we need to be thinking about, because they're also funded by NHS England. And in terms of leadership, why shouldn't we be knocking on their doors and saying, because they have innovation portals to connect individuals with ideas and solutions. So maybe that's one thing that we might want to kind of raise nationally and locally. So Adam, in Yorkshire, you've got a really proactive Yorkshire and Humber AHSN and a team that are looking at that type of thing. So maybe that's about targeting some of those individuals for your meeting next week and seeing if you can get them there and start to make some pledges. And ditto, in terms of the amazing work you're all doing, I'm just thinking we perhaps need to start sharing notes about where is fertile ground going forward and do a bit more of that horizon scanning, because we're all struggling, aren't we? But together, by pooling intelligence and what's worked, that's what we don't find much space for with different agencies and organisations. So maybe that's something that we can build into future meetings. So I'm not sure if that's a legacy hand. Laura, were you coming back on that?
Sorry, yeah, I didn't take it down.
No, don't worry. That and being on mute, we all do it all the time, don't we? So we absolutely know what that's like. I'm just having a check. Shan, can you see anything else?
No more questions in the chat box, and we're just a minute till the end.
Yeah. So maybe that's a point to end on, really. How can we get better at sharing what's effective in relation to advocacy and marketing, and who do we need to be targeting collaboratively so that, and I only use the AHSNs as an example because they have been at the forefront of supporting some cultural health innovations in the Northwest, where they funded quite a significant amount of work around House of Memories and dementia developments. So maybe we need to make a pledge ourselves and to identify an organisation or a conference programme package in the future that we're going to try and influence and infiltrate, and perhaps share that with everyone so that we can all build that momentum together. So I think the last thing to do in the time limited period of time we've got is just to say huge thank you for all the work that you put together to condense such an amazing amount of work in such a short space of time, and to remember that the networking begins here. Everyone can track everyone down through your badges, so please hunt each other down and keep in touch really in relation to how we make this transformative change together.
Thank you.
Thank you very much.
Thanks everyone, great to meet you all.
So one last reminder, you've got a slight break, and then don't forget for the next sessions, and obviously AirMeet is available as well to do some of that networking. Sarah, I was just thinking you have a lot of, I think you've got 2 HSNs in the London area that you could be having some conversations with. Everyone's gone now.
Nearly all gone. Well done.
It's really difficult to pull the threads from, often it's quite disparate between the actual chat and where we're at, if you see what I mean, to try and...
Well, I think you all gave them questions in between, so that started that pulling together, so you did it really well.
So hopefully, oh well, let's see where we get to anyway this time next year in terms of how we influence. You know, one of the things I always think is really interesting, because I used to do a lot of fundraising.
We're still recording those, Jo. I'll give you a call, okay?
Okay.
I think everyone else is leaving, are they? There must be.